This is Patrice Wendling at the Annual Congress of the European Society of Cardiology, speaking with Dr. Manesh Patel, who just presented results on the CRISPR-Me trial. Doctor, how would you characterize your results?
I find these results to be fairly interesting. I would say we took patients with acute myocardial infarction, large heart attacks, and sought to see if a device placed prior to reperfusion helped them to reduce their infarct size, and then we also followed them for clinical events. We did not find a difference in the size of the heart attacks the patients had. However, there was some interesting signals towards improved clinical outcomes, including a signal for patients with death, new onset heart failure, cardiogenic shock, that was statistically lower in the patients with the counterpulsation. So we conclude as a routine strategy, you shouldn't be putting the device in to reduce infarct size. There wasn't a difference in all-cause mortality. There is this interesting clinical signal that's a bit tantalizing to us, and so we want to explore it further, continue to open up arteries as fast as possible, and hopefully understand infarcts better.
How widely used is counterpulsation? It's been around for many years.
Yeah, it's been around since the late 60s, and I think most interventionalists feel very comfortable with the device. It was one of the reasons we were able to do the trial, since most of us feel comfortable placing the device in our routine practice at times. As an example, in the setting of the acute MI, interventionalists were able to place the device prior to opening up the artery, and it only extended the time by 9 minutes on median in this study, and it's an international study, so people around the world are able to use the device.
How should clinicians interpret this then, and in whom should they use counterpulsation?
So clearly the guidelines currently still recommend using counterpulsation in patients with cardiogenic shock and failing hearts at the time of a heart attack. What we aim to understand is those patients who weren't in shock but were teetering, did the device help? And routinely they shouldn't be using it in those patients. However, stay vigilant, make sure they're not deteriorating. If they start to deteriorate, consider the device.